everyone to today's webinar on primary prevention of CVD. We've got Dr. Matt Molloy as the speaker today. If you have any questions, please just pop them in the chat and that will have them answered at the end of the presentation. Just let everyone know as well, this will be recorded and so you'll be able to access the link in about a week after the webinar up on YouTube. So if anyone would like the link, please let me know and I can forward that to you. But I'll now pass over to Matt and thank you. Thank you.
Thank you, Jess. Thank you, Jess. So my name's Dr. Matt Molloy, and I'm a GP partner at Affinity Care in Bradford, and I'm a GPSI in cardiology. So I spend half my time doing seeing patients with a kind of leaning towards kind of cardiology problems in a primary care setting. So patients who are probably not severe enough to need secondary care attention, but are probably a bit more difficult for the average kind of primary care clinician to deal with. So I'm going to talk today about CVD primary prevention. I think probably a lot of us will kind of know a lot about it, but I'm just going to go over two main aspects, kind of the management of hypertension and the management of lipids, and just talk about kind of the cardiovascular disease kind of risk assessment tools that we use, kind of pitfalls and changes compared to tools that we've been using in the last 5 or 10 years. So just to start with a definition of what cardiovascular disease is. So cardiovascular disease is a term that describes a group of disorders of the heart and blood vessels caused by atherosclerosis and thrombosis. So as we all know, the process is the arteries become kind of clogged up with fatty plaques, atherosclerotic plaques. And if one of those ruptures, the body sends or goes into a protective mechanism to kind of form a clot around that ruptured plaque, and that causes a thrombosis, which blocks off the vessels which are providing blood and oxygen to the heart muscle and to the brain, and that leads to heart attacks and strokes. And obviously, it's a similar process that leads to peripheral arterial disease and aortic disease. So the risk of cardiovascular disease is greater in men, patients with a family history of cardiovascular disease, and in certain ethnic backgrounds such as South Asians. Cardiovascular disease is also greater in patients age over 50 and increases with age, obviously. Patients over 85 are particularly at high risk. Cardiovascular disease has several important and potentially modifiable risk factors such as hypertension, abnormal lipids, which I'm going to talk about today, and obesity, diabetes, and psychological factors such as depression, anxiety, and social isolation. So low physical activity, poor diet, smoking, and excessive alcohol intake are all modifiable risk factors. So the scale of the problem, so this is looking kind of nationally, so around nearly 30% of the UK population have high blood pressure. 35% of us aren't kind of meeting the recommended exercise levels. 1 in 8 of us smoke. 26% of us have obesity, and someone dies every 8 minutes from heart disease. In the UK today alone, 460 people will die from heart or circulatory disease. About 130 of those 460 will be under the age of 75. There'll be 260 hospital admissions due to heart attacks, and 180 patients will die from coronary heart disease. So the cost of this is astronomical to the healthcare system. So the annual healthcare cost of heart and circulatory disease in the UK is 9 billion, and the CVD cost to the UK economy is even greater. So this is kind of in premature death, disability, and informal costs resulting from the cardiovascular disease, and this is estimated to be about 19 billion per year. Sorry, this is a bit small, but this is a bit closer to home, looking at West Yorkshire, and unfortunately some of our statistics are a bit worse than the national average. So we have more obese people in West Yorkshire than the national average. We have kind of high percentages of smokers. There are 460 deaths each month in West Yorkshire attributable to heart and circulatory disease. We've got 270,000 people living with heart and circulatory disease. not enough of us are exercising, and there are 48,000 living stroke survivors in West Yorkshire. So quite startling kind of figures there. So a definition of primary prevention. So primary prevention aims to prevent disease or injury before it ever occurs. And I think everyone at all kind of levels of kind of healthcare provision would agree that it's better to prevent a first heart attack or stroke than it is to prevent a second or a third one when the damage is done. So I can't stress how important it is, and it's quite commonly a thankless task because you don't hear from the patients whose first heart attack or stroke you're able to help prevent, but it's massively important work and the kind of bread and butter of primary care. So primary prevention aims to prevent disease or injury before it ever occurs, and this is done by preventing exposure to hazards that cause disease or injury, altering unhealthy or unsafe behaviours that can lead to disease or injury, and increasing resistance to disease or injury should exposure occur. And this is from a definition from the Institute of Work and Health. So making every contact count, it's a phrase that I like, and it's just as an aid to me to discuss that everyone is involved in kind of CVD primary prevention. So within my kind of practice team, everyone is kind of grilled to make every contact count, be that the receptionist who, when they're talking to patients at the front desk, if they can see on the patient's notes that they haven't had their blood pressure or a BMI check, they can direct them into our health check room where the patients can do that, to the healthcare assistants and nurses and doctors. So if the patient has kind of attended for something else and if they have some spare time, or if there's prompts on the computer system, the clinicians can try and tick some of those boxes and action them if needed, and also kind of signpost patients to local services. But we get lots of information about primary prevention from outside the practice setting as well. So there's numerous kind of volunteer services checking blood pressure. Community pharmacists are becoming increasingly active in checking patients' blood pressures, and we get lots of kind of messages from patients and from pharmacists about kind of health statistics that we need to action. There are initiatives, certainly in my area in Bradford, where there are community health teams who are going into groups of patients or cohorts of patients who are difficult to access, the patients who are where English isn't the first language, where there are problems with kind of drug abuse, homelessness, sex workers, migrants. So there are lots of kind of initiatives currently to try and increase the uptake and kind of case finding of patients who may need help with their blood pressure and lipids and blood sugar. And there are also kind of multiple kind of opportunities to have your blood pressure checked these days at supermarkets and kind of shopping centres. There's various private organisations who are keen to check these statistics and pass them on. So wherever this information comes from, we need to be assimilating it and kind of incorporating it into the patient's kind of management plan. So the NHS health check, which has kind of been going for a long while, is kind of one of many kind of measures to try and improve the uptake of checking patients' cardiovascular status. And the NHS health check helps to prevent or detect diabetes, heart disease, kidney disease, stroke and dementia. And it has been running for many years, like I said, with kind of a fair degree of success. And there is kind of financial incentives to primary care to completing NHS health checks. So an overview of the health check. So the top section is identifying the patients who are eligible for the NHS health check, and these are patients who are between the ages of 40 and 74. We kind of obviously search for these patients. So these are patients who have no pre-existing conditions, which would exclude them from an NHS health check because they hopefully will be on a register and getting the care that they need. But we invite the patients in, and invariably it's a healthcare assistant or a nurse appointment, and the BMI is checked, blood pressure is checked, questions about alcohol, smoking, how much exercise they're doing, questions about family history, and then cholesterol is checked as well. If there's no major concerns, or if the kind of clinician doesn't think any further actions needed at this time, the patient is kind of put on a list for further review in the future, and the advice is every 5 years, but that can be gauged based on the kind of degree of need. Obviously, if there's any kind of advice that needs giving, the patient can be signposted to smoking cessation services, local alcohol services. We have lots of, in our practices, I'm sure other practices do, we have lots of posters up for the local services available. We have patient information leaflets to give out, and we use the comms annex to email and text a lot of patient information leaflets, and we employ patches to send information out as well. If the healthcare assistant has identified cause for concern, then a more formal assessment is undertaken, and this is kind of for checking for diabetes, further check of the blood pressure, checks for chronic kidney disease, and if after risk assessment, which we'll kind of talk about a bit later, their Q risk is greater than 10%, to consider statins. After all the information is collated from blood tests, urine tests, ECGs, and whatever else is felt as needed, the patient is going to start on medication, given lifestyle advice, and signposted for referral if needed. And then again, depending on what has been found, in which register they will end up on, they will be arranged or have follow-up arranged accordingly. So cardiovascular disease risk assessment. So NICE 2016 recommends that for primary prevention of cardiovascular disease in primary care, a systematic approach be used to identify those who are likely to be at high risk. So patients should be prioritised based on an estimate of their cardiovascular disease risk using risk factors already recorded in their records before a full formal risk assessment is undertaken. And priority for a full formal risk assessment should be given to patients with an estimated 10-year risk of 10% or more. And patients over the age of 40 years should have their estimate of CVD risk reviewed on an ongoing basis. Usually that is 5 years, as I've said, but that can be kind of agreed with the patient. So the risk assessment tool, which I'll go on to talk about, is Q risk that we usually use, but the risk assessment with a calculator is not required in patients who are at increased risk or high risk of cardiovascular disease. So this includes those patients with cardiovascular disease already established, those with higher stages of chronic kidney disease, albuminuria, or a suspicion or diagnosis of familial hypercholesterolemia. In addition to these patients, NICE doesn't recommend the use of risk calculations in patients with other hereditary lipid disorders or type 1 diabetes. And this is because these cohorts of patients obviously are so high risk that regardless of the Q risk, we're going to want to do everything we can to control their blood pressure and get them on statins. So there are other risk assessment tools available. Q risk is the one that we use. Well, certainly I say what we use in Bradford in my PCN, but other PCNs may use JBS3, and in Scotland they use a SIGN risk assessment tool. So unfortunately, despite lots of conversations and pushing to get Q risk 3 on system 1, we still only have Q risk 2 on system 1, which is a bit more crude and less refined than Q risk 3. And you can find Q risk 3 if you Google it, and it's a far more sensitive tool for calculating risk. So I'll just run through what is on a Q risk 3. So the patient's age, sex, and ethnicity, the postcode just as a marker of deprivation, and more weighting obviously is put in the more deprived areas of the UK. Smoking status, diabetes status. If the patient has a first degree relative to someone under the age of 60 who's had angina or a heart attack. If the patient themselves has CKD 3, 4 or 5, history of AF, if they're already on blood pressure treatment. These are newer ones following this, so these weren't on Q risk 2. So the next one is migraine. So the thinking is that patients who have migraine and where they have the kind of vasospasm of the arteries, this can cause arterial wall damage, which can lead to inflammation and atherosclerosis. There's lots of kind of association with inflammatory disorders. So it says rheumatoid arthritis and SLE, but also psoriasis. So any inflammatory process can increase the risk of atherosclerosis and cardiovascular disease. Severe mental illness. So these patients, unfortunately, are less likely to look after their general health. So there's a higher degree of obesity and alcohol problems and smoking in patients with severe mental illness. So that is sufficiently weighted to be an independent risk factor. Atypical antipsychotics and steroid medications are also given weight, and these can affect lipid metabolism, and they can also affect blood pressure. So that they are kind of direct cardiovascular risks. The final one is a diagnosis or treatment for erectile dysfunction. And obviously, if a patient has erectile dysfunction, this is a red flag to say that their arteries are blocking up elsewhere. The cholesterol HDL ratio is entered into the risk tool, and the patient's blood pressure as well. And whereas QRISK 2, there was no weighting given to standard deviation. On the QRISK 3, it takes into account the most recent blood pressure readings rather than the most recent. And then obviously height and weight. So lifestyle modifications. So all patients at any risk of cardiovascular disease should be advised to make lifestyle modifications that may include beneficial changes to diet, so increasing fruit and veg, reducing saturated fat and reducing dietary salt intake, increasing physical exercise and weight management. So the current advice is for patients to be exercising for moderate exercise, which is walking kind of a couple of miles in 30 minutes 5 times a week, or more kind of heavy intensity exercise for 20 minutes 3 times a week. Reducing alcohol consumption. So the current, obviously, current guidance is 14 units, but I think that the way things are going, that will kind of go down to 0 in the not too distant future. And smoking cessation, and obviously signposting patients for help with this. And an annual review should be considered to discuss lifestyle modification, medication adherence, and risk factors. And the frequency, again, as I've said, of the review may be tailored to the individual. So further preventative measures with drug treatment should be taken in individuals with a high risk of developing cardiovascular disease. So just an overview of primary prevention. So it's a long time since we used to prescribe aspirin for primary prevention, but it still comes up. And I don't know whether other people have it as questions, but quite frequently I'm asked, should we start this patient on aspirin? And the answer is no for primary prevention. So that the risk of significant bleeding far outweighs the benefits it's going to do them for primary prevention. Aspirin should only be used for secondary prevention. Not so many years ago, we did go through a lot of our patients and take them off aspirin if they were on it only for primary prevention. Antihypertensive therapy, so antihypertensive drug treatment should be offered to patients who are at high risk of cardiovascular disease and have a sustained elevated systolic blood pressure and diastolic blood pressure, and/or. And then lipid modification therapy. So NICE again recommends low dose atorvastatin for patients who have a 10% or greater 10-year risk of developing CVD, and for patients with chronic kidney disease. Low dose atorvastatin should be considered in all patients with type 1 diabetes and be offered to patients with type 1 diabetes who are either aged over 40, have had diabetes for more than 10 years, established nephropathy, or have other cardiovascular disease risk factors. You're not going to get an 85-year-old who's got a low Q risk, obviously, but all patients over the age of 85 may also benefit from a low dose of atorvastatin to reduce their risks of non-fatal myocardial infarction. So I'm going to move on to discussing aspects of lipid management. I've included at the end the guidance that we use at Affinity Care, which is adapted from NICE guidance, but it's the same thing. But the total lipid guidance is so huge it won't fit on one page. So I've just condensed it purely to primary prevention and the guidance that we use within our PCA. So considerations prior to starting statins. So use of clinical findings, lipid profile and family history to judge the likelihood of a familial lipid disorder. And I'm going to discuss when we should be suspicious of kind of blood test results which might suggest familial hyperlipidemia. It's also important to exclude possible secondary causes of dyslipidemia, such as excess alcohol. So pick that up in the history and maybe in the blood tests. Uncontrolled diabetes. So we need to control diabetes as a priority and then consider rechecking the cholesterol. But again, these patients will be on a statin. Hypothyroidism. So if their thyroid is out of kilter, that can affect lipid metabolism. And we need to make sure that that is treated to target before making further decisions. Liver disease can affect it, and also nephrotic syndrome. So we need to discuss the benefits of lifestyle modification and optimize the management of all modifiable cardiovascular disease risk factors, including any relevant comorbidities that may not be optimally treated. So many patients say they would like to try diet lifestyle measures before committing to further treatment, and I think for a lot of patients we need to honour that. It is obviously difficult to change patterns and to maintain patterns, but we should be, if that's the patient's choice, we should be making sure that they're given all the kind of tools to help them and make sure they're signposted to be signposted to all the kind of relevant voluntary and kind of healthcare offered services to help them achieve improved lipids without statins. So again, we've talked about the kind of higher Q risks, but don't rule out lipid modification therapy for the primary prevention of CVD just because a patient's 10-year risk is low. Lots of patients have kind of quite shocking family history that might not show up in the Q risk. I not infrequently prescribe patients a statin with a Q risk less than 10 if they have significant concerns about family history or other risk factors. And obviously, again, mentioning it a lot, and we'll discuss it later, if we suspect familial hypercholesterolemia, we should be kind of assessing a patient for that and actioning it. So I use this tool, which is on the NICE website, to discuss statins with patients to try and encourage them to take them. It's not always an easy kind of conversation to have, because there has been lots of negative press about statins and there has been reluctance to take them. And it's one of those medications that is a little bit of a difficult sell, because you can't tell an individual how much it will benefit them. It's a medication that benefits populations. So these tables are good to show a bit more kind of simply how taking a statin for a prolonged period of time may improve their health. So this is for a patient with a Q risk score of 10%. So on average, for every 100 people with a Q risk score of 10% who do not take a statin over 10 years, 90 won't have a heart attack or a stroke, but 10 will. So if these same 100 people take a statin over 10 years on average, about 90 people will not get heart disease or a stroke, but would not, even if they had not taken a statin. About 6 people will get heart disease or have a stroke even though they've taken a statin, but about 4 will not get a heart disease or a stroke because they take a statin. So obviously, as we move up the Q risk scores, the kind of, you can see the benefits to taking them. So for 20%, so if 100 people take a statin over 10 years on average, about 80 of them would not have a heart attack or a stroke. But again, they wouldn't have even if they had not taken a statin. About 13 people will have heart disease or stroke even though they did take a statin, but 7 will have a heart attack or stroke avoided because they took a statin. The higher it goes up, the more people obviously are having heart attacks and strokes, and the more people are benefiting from it. So if you go up to 35%, so of 100 people taking a statin, 65 will not get heart disease or have a stroke. But again, they wouldn't have had if they had not taken a statin. 22 people will get heart disease or have a stroke even though they take a statin, and 13 will avoid heart disease and stroke. So I sometimes find these tables are quite useful in explaining the potential benefits and giving patients or allowing patients to make more of an informed decision. Another big question about statins is side effects, and this is one of the larger reasons why patients are reluctant to take statins. So muscle pain is probably one of the bigger ones that patients worry about and complain about when they start the statin. But statins can cause muscle pain, but many people get muscle pain from time to time, regardless of whether they take a statin or not. And this diagram shows how many patients will get muscle pain as a direct result of taking a statin. So again, for every 100 people who take a statin, about 72 will not get muscle pain. 26 will get muscle pain, which they would have done regardless whether they took a statin or not. And about 2 got muscle pain because they took a statin. So around 2 out of the 100 would get muscle pain. And it seems in kind of primary care that we get a lot more kind of pushback and questions about that than this table would suggest. So I would encourage you to kind of be confident in telling patients that it's a very, very small kind of side effect. There's a small percentage chance of the side effect, and it's much more likely that their muscle pains are due to something else. Very rarely, patients can get severe muscle damage, and this happens to a very, very, very small amount of patients. This is about 3 in 10,000, and this is rhabdomyolysis. So, if a patient has muscle pain prior to starting, so talk about creatinine kinase here on the right of the screen. So, I wouldn't routinely check creatinine kinase unless the patient was complaining of muscle pain. Kind of generalized, persistent, unexplained muscle pain, and I was thinking about starting them on a statin. So there are some reasons why a patient might get kind of a raised creatinine kinase. So if they kind of exercise kind of really vigorously, or if they have a job which is involving kind of heavy lifting or kind of well, using the muscles are kind of more than the average job. So with creatinine kinase, we say if the baseline concentration is more than 5 times the upper limit of normal, we'd repeat it again in 7 days. But if it remains that high, we would kind of advise you not to start a statin. And again, if we suspect kind of rhabdomyolysis, we would be checking patients on statin with their creatinine kinase. But it is very, very rare, and the patient's symptoms tend to be quite severe. Another kind of less kind of nowadays kind of mentioned side effect is association is diabetes. So if you don't have type 2 diabetes, taking a statin increases your chance of getting it very, very, very slightly. So on average, for about 100 people, 95 people on the statin wouldn't get diabetes, 4 people would have got diabetes regardless of the statin, and 1 patient would have got diabetes because of the statin. And the mechanism isn't completely understood, but it's felt to impair glucose tolerance and affect insulin metabolism. Liver function is, but so obviously certainly kind of that isn't a reason not to prescribe a statin. And again, if patients have diabetes, statin's the mainstay of treatment as well. So liver function, liver enzymes should be measured before treatment and repeated within 3 months and 12 months of starting treatment. Those with serum transaminases that are raised but less than 3 times the upper limit of normal should not be routinely excluded from statin therapy. Those whose serum transaminases exceed 3 times the upper limit of normal, we should be discontinuing the statin therapy, giving them a kind of washout period, seeing if there are any other reasons why those blood tests might be as they are, and then reintroducing statins when the blood tests are more normal. So statin intensity. So we have high intensity, medium intensity, and low intensity statins. The ones that we use currently in kind of primary care atorvastatin, and then if it's not tolerated, rosuvastatin. So the usual dose that we're using for primary prevention is atorvastatin 40 milligrams, and the percentages on this table are the kind of percentage reduction in LDL cholesterol. So you can see the atorvastatin 40 milligrams will kind of reduce your LDL cholesterol of up to 49%. If atorvastatin isn't tolerated for whatever reason, and if it's not a class effect, we usually go for 5 or 10 milligrams of rosuvastatin. We still have patients historically on simvastatin, pravastatin, fluvastatin less so, but you can see from the stats there that the doses that we prescribe simvastatin on are far kind of inferior in reducing LDL cholesterol than the atorvastatin and rosuvastatin. And again, we're certainly in our PCN, we're not switching people over unless their kind of LDL cholesterol is significantly raised, and we think we need to change. So if they're established on one of the other statins, we're not changing. So, sorry, some of the writing's a bit kind of small here. So this is what we use in our PCN, which is just adapted from the national guidance. So this is purely primary prevention of lipid therapy. So if the patient has an elevated Q-risk score, Q-risk 3 score, if they have CKD 3 or above, if they have type 1 diabetes, if they're aged 40 or over, if they have nephropathy of diabetes for 10 years or other CVD risk factors, atorvastatin 40 milligrams is the one we use. If they don't tolerate it and we don't think it's a direct statin problem, we could try rosuvastatin 5 or 10 milligrams. So in years gone by, we were firing and forgetting. So for primary prevention, we were paying no heed to numbers or stats. We were just thinking, if we have got the patient on atorvastatin 40 milligrams, job's done, we don't need to do anything further. But obviously over recent years, we've been given guidance. So now the LDL target is less than 1.8, or the non-HDL target is less than 2.5 millimoles per litre, and the non-HDL cholesterol is obviously the total cholesterol minus the HDL cholesterol. If we don't achieve these targets, then we increase the atorvastatin to 80 milligrams. If statin is contraindicated, intolerant, we use a combination drug, ezetimibe and bempedoic acid. It is significantly less effective in reducing LDL cholesterol than the statins, but it's better than nothing. If the patient high-dose statin, atorvastatin, does not achieve the level of LDL cholesterol reduction, then we can add in Nustendi, which is ezetimibe and bempedoic acid on top of this. Obviously, for secondary prevention, we have injectables and other more novel therapies, but for primary prevention, it's atorvastatin and Nustendi only. And I put a little bit about familial hypercholesterolemia there, so I think that's the next one. So when should we be suspicious of familial hyperlipidemia? So we use kind of two tools in our PCN. We use the Dutch lipid network scoring and the Simon-Broom criteria. And I've just mentioned the Simon-Broom criteria for familial hyperlipidemia here. So hopefully you've all seen this before, but I'll just kind of explain it. So a first degree relative is a biological parent, a sibling or a child, and a second degree relative is a biological grandparent, uncle, aunt, niece, nephew, half sister or brother. So for a definite familial hypercholesterolemia diagnosis on the Simon-Broom criteria, you have to have points 1 and 2 or 3. So you have to have, as an adult, a total cholesterol over 7.5 or an LDL cholesterol greater than 4.9, or a younger person or child, the cholesterol has to be 6.7 or the LDL greater than 4. So in addition to this, they need to have tendon xanthoma in the patient themselves or in a first or second degree relative. And again, the picture on the right there shows what a tendon xanthoma is. So they're pretty hard to miss. So the big kind of fatty deposits on the Achilles tendon. Deposits of cholesterol elsewhere aren't given the same weighting as tendon xanthoma. So if you only remember one clinical feature or sign or symptom, that's the one to remember. And then the third one is if they have genetic evidence of kind of mutations which would lead to familial hyperlipidemia in themselves, but obviously it's more likely to be in a family member and come as second-hand information. Possible familial hyperlipidemia is if the patients have the cholesterols and LDL cholesterols mentioned above, along with a family history of a myocardial infarction in a relative aged 50 or younger, in a second degree relative, or age 60 or younger in a first degree relative, or if they have a family history of raised total cholesterol. So if they have a sibling or first and second degrees, if they have a family history of raised cholesterol. But again, we do find lots of families like that, so it is sometimes a difficult decision to make. But if it's suspected, we would suggest referral to endocrinology or one of the kind of several lipid clinics that are around the region. There's absolutely no problem if you're concerned if they have an eye-watering LDL or cholesterol to start a statin prior to referring them. And the blood tests that we do, they don't need to be fasting. So if we move on to blood pressure management, so some considerations when taking kind of blood pressure. So quite frequently, a lot of us will use automated devices, and these may not measure the blood pressure accurately if there is a pulse irregularity. So if the patient has AF, the blood pressure on an automated device may be kind of over or underestimated. So we advise to palpate the radial or brachial pulse before measuring the blood pressure in all patients. Obviously, this is a good way to pick up suspected atrial fibrillation as well. But if the pulse is irregular, we need to be measuring the blood pressure manually using direct auscultation over the brachial artery. So when measuring patients' blood pressure in clinic or in the home, we need to try and standardise the environment as much as possible and provide a relaxed, temperate setting. Patient needs to be quiet and seated, their kind of legs not crossed, arms outstretched and supported. And it's really important that we kind of choose a cuff size that kind of fits the patient's arm properly and comfortably. When considering a diagnosis of hypertension, we should be measuring blood pressure in both arms as well. If the difference in readings between arms is more than 15 millimeters of mercury, we need to repeat the measurements. If this persists, we need to use the higher reading in the reading in the higher arm as the blood pressure to go on. And changes or disparities in blood pressure between arms can be a kind of a red flag that this patient has kind of severe cardiovascular disease, or it can hint at other things such as coarctation of the aorta. But I think if we see a disparity, we should be thinking this patient is likely an arteriopath, and we should be kind of doing as much as we can to kind of get them on primary prevention. So ABPM versus home blood pressure monitoring. So availability is a problem. So not all PCNs have access to ABPM. It is, according to NICE, the gold standard, and if possible, we should be trying to use ABPM over home blood pressure monitoring. Certainly in younger patients, I try to do ABPM where the kind of stakes are higher and the patients are likely to be on tablets for longer periods. We need to ensure that their blood pressure definitely is elevated, and ABPM is the most sensitive way to check that. But if that isn't available, if the waiting lists are kind of for your machines are going to be months and months, then home blood pressure monitoring is acceptable. And there are kind of a cohort of patients again who don't tolerate 24-hour blood pressure monitoring. They find it very intrusive to the working day. We do tell patients that they don't need to wear it at night, but if they do, it can give us good information about kind of dipping and non-dipping, which can help to guide treatment. And we also need to make sure that the cuff again is the right size. So quite frequently we see patients who are not given the right cuff on an ABPM, and that's the reason it's hurting them so much. But if we decide to do home blood pressure monitor, we should be asking the patient to take the blood pressure over 7 days. So they should be kind of sat down for a few minutes, kind of in a quiet environment, doing the kind of things we discussed on the last slide. Check the blood pressure 3 times and write the lowest recording of the final 2. And if they do that twice a day over 7 days, and then calculate an average for us and send it in or drop it in, then we can kind of base kind of either diagnosis or kind of further management on that. So if we're suspecting kind of blood pressure, the things that we should be doing alongside this are kind of clinical examination, so checking the patient's BMI, the pulse again, checking for target organ damage, so looking at the fundi to see if there's any retinopathy. If kind of, as many of us are kind of, we don't feel kind of sufficiently skilled in using an ophthalmoscope, it's completely reasonable to refer a patient to the optician to have this done. Bloods that we might consider, so thinking of other kind of metabolic or kind of other reasons in the blood test why their blood pressure might be up, so making sure they're not anemic, again checking the U's liver bone profile, CK if needed, lipids, HbA1c, and make sure they're not over or underactive with the thyroid. Checking for chronic kidney disease and using again the ECG to look for target organ damage, looking for kind of voltage criteria for left ventricular hypertrophy, looking for any ischemic changes which might alter our treatment, and looking for obviously kind of the rate and the rhythm, looking for atrial fibrillation and other arrhythmias which might need some treatment. So this is a common kind of concern. So if the blood pressure is very, very high, so this is what we would class as stage 3 hypertension. So if a patient's blood pressure is over 180, over 120, and that doesn't mean both the systolic and the diastolic, it needs to be higher than that. So it could be 150 over 125, or it could be 190 over 110. So just one needs to be kind of elevated for it to be stage 3 hypertension. So it's quite a common scenario in primary care where we have, certainly as a GP, we have someone coming in to us saying that we've checked this patient's blood pressure and it's really high, and we need to decide what we need to be doing there and then. So if they've had some kind of investigations, so if there is evidence of target organ damage, but they're well, we can start medications immediately without waiting for the results of the ABPM. But obviously when we get the results, we need to kind of bear in mind that they're on a medication during the test. And then we would be getting these patients back fairly quickly. It says 7 days, but sometimes we get them in a bit sooner just to make sure that their blood pressure is coming down and we can up titrate. So the patients that we tend to worry about are the patients with what we call malignant hypertension, and they're usually not well people. So it would be unusual for them to be kind of sitting down, kind of chatting. They would likely have kind of life-threatening symptoms such as kind of confusion, chest pain, signs of heart failure, kind of acute kidney injury. So these patients would be usually fairly obvious to pick out that something was kind of seriously wrong and we needed to do something. Another cohort of patient is patients who have kind of a swinging blood pressure or a labile blood pressure, which might make us be suspicious of pheochromocytoma. So if they have a really swinging kind of blood pressure in clinic, if they're complaining of serious headaches, if they're having palpitations, if they're pallor, if they have abdominal pains, if they're sweating profusely, again, not well people, these are the patients that we should be either liaising with our secondary care colleagues for urgent admission or sending them down to A&E. So it was a few years ago now, I think it was 2016. So there was a big meta-analysis in the Lancet showing the benefits of blood pressure reduction. So it found that looking at kind of several studies that a 10 millimeter mercury reduction in systolic blood pressure reduces our risk of major cardiovascular disease events by 20%. So it reduces coronary heart disease by 17%, stroke by 27%, heart failure by 28%, and death from all causes by 13%. So this is the kind of guidance that we use within our PCN. So this is how we kind of diagnose hypertension and manage ABPM results. So we get the patient to have 3 clinic readings, and again, if the blood pressure is kind of extremely high, we take into consideration the last slide, whether we do anything on the day or whether we start treatment whilst waiting for further investigation and bring them back soon. If the blood pressure is less than this, they don't have known stage 1 or stage 2 hypertension, we'll arrange a 24-hour blood pressure monitor ideally. If they have known stage 2 hypertension and their blood pressure is raised, we will manage them as the protocol, which is on the next slide. And if they have been diagnosed with stage 1 hypertension and their blood pressure is kind of elevated compared to the previous reading, we'd consider asking the patient to drop in a home blood pressure monitor or an ABPM if it's 9 months since the last check. So the ABPM results, so we consider less than 135 over 85 normal. So these patients, we don't say everything's fine. We talk to them, we discuss any kind of risk factors they may have and suggest signposting and kind of reassess them within 3 years to make sure that the blood pressure is not creeping up and they haven't accumulated any other risk factors. If their blood pressure is between 135 over 85 and 150 over 95, and they have no established cardiovascular disease and a low risk, we class this as stage 1 hypertension. Again, kind of aggressive lifestyle advice and annual review. If their ABPM result is the same, but they're a known CVD, or if they have an elevated Q risk, we class this as stage 1 hypertension with organ damage, and we offer lifestyle advice again, but we also treat this cohort with medication. With ABPM result greater than 150 over 95, we class it as stage 2 hypertension, and the lifestyle advice again, and kind of up titrate and optimize medication to achieve targets. So again, this is slightly different to NICE guidance, but this is what we used in our PCN. So because we find that blood pressure agents on their own tend not to have a kind of they tend not to drop the systolic blood pressure more than 10 or 15 millimeters of mercury. We tend to go in fairly aggressively with 2 agents. So you can imagine if a patient's ABPM is 160 over kind of 95, they're going to need more than kind of 1 tablet to bring their blood pressure down to the target of 130 over 80, which is what we aim for. So to try and reduce the wastage of appointments, to try and reduce the kind of frustration in patients having to have multiple appointments where they keep coming back and having kind of ACE inhibitors and ARBs kind of slowly up titrated. We start with 2 agents. So we start with a calcium channel blocker and an ARB. So we start with, in our PCN, with amlodipine and candesartan 8. If that doesn't control the blood pressure to target, we'll bring them back after a couple of weeks. We'll add in indapamide, so we're quick to get them on to 3 agents. If that doesn't work, we'd first up titrate the candesartan, then we would up titrate the indapamide. We find, as most people do, that going to higher doses of amlodipine will cause side effects with ankle swelling, and it's less tolerated. So if they're on the kind of higher doses of the candesartan and the indapamide and the blood pressure is not to target, we would switch the calcium channel blocker to lercanidipine 20 milligrams. If that wasn't controlling the blood pressure, we'd add in a 4th agent, and that's usually spironolactone. The BNF, the NICE guidance suggests after this we can consider alpha and beta blockers, but they tend to be far less effective and efficient in kind of reducing the blood pressure, and they do have more side effects with kind of heart rate and also kind of postural hypertension with the alpha blockers. If the patient's blood pressure remains high on 4 agents, and if we've discussed compliance with them, if we're happy that they're taking it, but still their blood pressure is high, then we would consider an e-consult or to our kind of GPSI service or to cardiology for further advice. And they would look into making sure that the patient was adherent, making sure the patient understood the medications, making sure there weren't any kind of factors that were kind of, or barriers to taking them. And then if they were satisfied that they're taking the medications as prescribed, look into possible secondary causes. There are medications obviously that we can use on top of these, but in primary care we say if you're on those 4, so calcium channel blocker, an ARB, indapamide, and an MRA in spironolactone, that's as much as you need to be doing. Regarding tests, patients use these 2 weekly after the candesartan, 2 weeks after the higher dose indapamide. With spironolactone, obviously the worry is with hyperkalemia and kind of deteriorating renal function, so we keep a bit of a closer eye. So at kind of weeks 2, 4, 8 and 12, we recheck their using ease, and if they're stabilized on it and they're kind of using ease that are fairly stable, we would check it every 6 months. If they're not on spironolactone, we would check them annually, and if they're on spironolactone, obviously we check them twice a year. So I'm coming towards the end now. So I think, so if patients, these are some of the considerations that we can be thinking about. If we have a patient on multiple blood pressure tablets and they are not being controlled to target, or there are possible suggestive features or signs that a patient may have a secondary cause of hypertension before we even start treatment. But we tend to kind of be more concerned with patients who are less than 35. Some say 40, but we tend to have 35 as a cutoff. So with these patients, by far and away the more common secondary causes tend, if there is a secondary cause, and usually there isn't, usually it's kind of genetic, it's usually kind of weight related. But if there is a secondary cause, it's usually an endocrine cause or a vascular cause. So it's not that easy to detect, but you can kind of listen to a patient's tummy and hear if you can detect a renal bruit, which is like a carotid bruit, just kind of an abnormal whooshing sound. But a hallmark of renal artery stenosis is if you kind of start them on an ARB or an ACE and you notice a significant creatinine increase, that is a warning sign that there might be renal artery stenosis. Endocrine causes, again, thyrotoxicosis. Hopefully you would have detected a raised thyroxine level in your kind of workup bloods prior to them needing kind of medication, but if not, recheck it. Certainly if they've got heat intolerance, if there's been any period disorders, if they're tachycardic and have a tremor. Con syndrome, so hyperaldosteronism is a very common one, and that can sometimes present with a high potassium that you can check for in the using ease, which is again a common workup blood test that might give a clue. Pheochromocytoma, again, which I've mentioned. Cushing syndrome, so if the patient is obese, if there are kind of stretch marks, if they have kind of facial features and kind of easy bruising, we should be kind of considering kind of hormonal tests. And for these kind of hormonal tests, other than the thyroid, we can, and for cons, which is a renin-aldosterone level, we can check for VMAs and for cortisol in the urine to exclude these. And if they are borderline or raised, we can refer on to endocrinology. Another big kind of cause that you see is obstructive sleep apnea. So if a patient, again, is obese, if they're snoring, if there's daytime somnolence, it's important to calculate an Epworth score and refer them on for sleep studies. And you do quite frequently see patients with obstructive sleep apnea when they have the CPAP, and when it's treated, their blood pressure will normalise. And again, obviously, there's a whole raft of different medications that a patient can be on which might affect the blood pressure.